Hi guys, welcome back to week 2. I'm hopeful that you guys had a great week 1 and really got through module 1 without any issues. So today we're going to start our lecture with the review of module 1. I just wanted to let you know I did add quite a few resources and websites for your reference under module 1, right under the lecture posting. So please go in there and do yourself a favor, create a file in your computer and add those websites for your reference. I will go through what the websites are in just a minute, but going forward in your career as an NP, you are going to need access to those sites pretty frequently, if at least yearly, for licensure renewal, licensure, just questions, as well as making sure you're meeting all of your requirements every year. And then we're going to get into module 2 today. And then in here, our chapter 80 and the PowerPoint today, we're going to cover various things, including the U.S. healthcare environment right now, the review of the third-party payer roles, the basics of the Affordable Care Act, the essentials of business practice, specifically in starting a business as a APRN. Current reimbursement rules and CPT coding, extremely important for you to learn this. So please make sure you are paying attention and also tapping into the additional resources I put up on Canvas to actually help you practice coding. We're going to be reviewing tips for measuring and communicating your value as a nurse practitioner, and also information in terms of managing a healthcare practice. Again, this goes into business practice and management needs as a nurse practitioner practicing independently. All right, guys, so here we go. Please try to keep along. There are about 60 slides in this presentation, and I'm going to go through them quickly because there's a lot to cover. So please try to stay focused. All right, so review of module 1, just so we can just review what we talked about in each chapter. So chapter 2, we went into caring and the advanced practice nurse. And here in the bottom left corner, you see the different factors that are involved in the APRN thought process in caring, including the attributes of courage, authentic presence, advocacy, knowing, commitment, and patience. Okay, just know that model, very important. We did get into evidence-based practice, where we talked about the hierarchy of evidence and how to do peer reviews, article reviews, and what you're looking for in terms of levels of evidence and what really is authentic evidence that you can use in your practice. We also got into chapter 79, ethical and legal issues of a caring-based practice, including the basics of beneficence, non-maleficence, distributive justice, and respect for autonomy, making sure you know those ethical principles are key for your exam here in FNP II, as well as for your boards in the future. Chapter 82, we got into putting care into practice in terms of caring for the self. I hope you guys reflected on that at some level this week. I know you're probably stressed out and can't even imagine adding one more thing into your schedule, but keeping yourself from getting burned out by practicing self-care is the key in balancing everything, not only as a student, but as a nurse practitioner when you actually start practicing. Believe me, as a student, you're very busy. As a nurse practitioner, once you're practicing, you are also extremely busy. So finding balance now and finding balance later, or actually finding balance now will make it a lot easier for finding balance later. It's in the best interest of both yourself and your patients, as well as your colleagues. In terms of evidence-based practice, we did review the importance of research and scientific evidence in literature. For this particular module, module 2, I did post an article from the Journal for Nurse Practitioners on telehealth billing. I would ask you to please read that, review it, make sure you're reviewing it from an evidence-based practice in terms of remembering how to review an article, reviewing the abstract, looking at what level of evidence is within the article, if there is any, what type of review it is, and utilizing the information in that article to help kind of conceptualize the points of the coding that we're going to discuss today. In terms of that article in the module 2, please focus on the bold headings, look at your background, look at your CMS policy updates. That's on page 259 of the article. You really want to review the updates that were brought on by COVID and reflect on how also your practice may have changed in terms of your coding and policy updates within your practice. There is a table, summary of Medicare telemedicine services from the Centers of Medicare and Medicaid Services.
It's
right
1 o'clock.
on that, in that article, that's also very helpful just to glance at in terms of coding. And also the table on page 261 gives you a great reference of resources specifically for telehealth. So if you had any questions about how telehealth is being billed, they give you the different resources that you can click on. They also have a table in there that's great in terms of giving you some information regarding how the common insurance carriers are allowing for telehealth to be billed. All right, so this is a great article in terms of referencing what you're learning today, because we're learning about coding. Primarily, our focus is going to be within primary care, but I want you to realize that coding in general is different in terms of different settings. Okay, so another thing to review from last week, I just wanted to point this out. We talked about the steps to professional licensure. I did go ahead and post all of these websites in module 1. These are the sites I was telling you about that you really should bookmark for your own reference going forward in your career. So just to review the journey of the nurse practitioner and what it takes to become a nurse practitioner. First things first, you need to apply for certification after you complete your accredited program, which you're currently doing at Goodwin. So once you graduate and you have met all your credit criteria as well as your clinical hours, then you are eligible to sit and apply for certification. So once you finish all your, you graduate from Goodwin, Goodwin will then take all of your transcripts and all of the information and things that you have achieved here in Goodwin, and we will send it to the credentialing center of your choice. So here you have 2 certification options. This is always something that confuses students in the beginning when you first think about it. I know when I was a grad student, we didn't even have any of this information kind of laid out for us like we're doing in this class. When Professor Kavanaugh and I sat down to develop the curriculum for FNP II, we wanted to really make sure that we literally took an entire lecture so specifically for the business of an APRN and how you get to become an APRN, as well as the coding and the business piece of it. Because, Professor Kavanaugh and I both in our programs did not have that much exposure to this particular subject. And I definitely would have now that I'm in practice, would have really loved for somebody to lay it out like this for me too, because it gets a little confusing. So anyway, in terms of applying for certification, once you graduate and you've done your clinical hours, you can pick from the ANCC, or the American Nurses Credentialing Center, or the AANPCB. And not to confuse you with all these initials, but that's how they list themselves, ANCC or AANPCB. Just be conscious that there are 2 different certifying bodies. You can do the American Academy of Nurse Practitioner Certification Board, or you can do the ANCC. I particularly went through the ANCC, and it's funny, when I had to pick which credentialing option or certification option I wanted to do, I had no idea. Nobody explained anything. Nobody even told me really the differences. So I just went to the smartest student in my class and I said, "Hey, Rich, which certification exam are you going to take?" And he said, "I'm doing the ANCC, Jess." I was like, "Okay, I'm in." So that's how I decided. But, there are differences. Some people say one is easier than the other. They're both multiple choice and have an extensive amount of questions. I would suggest you look at either certification option on their websites and see what you could, they offer like 10 or 15 different practice questions from each one on their sites. Go ahead and look at them and see how they're laid out differently and what you want to do. There is talk that at the ANCC certification is geared more towards people who plan on furthering their education and going for their doctorate, because it does tend to have a little more questions regarding like nursing theory and that sort of thing. But they're both certification options, and they both prepare you to be certified by the board. So by a certified board. So that's the important thing. So either or, neither is better or worse than the other. So you pick which certification option you want to take. You go and sit for your boards through this certification body. And once you get your certification, then you are allowed to now apply for your license. So now next you have listed your state licensure websites. I listed both Connecticut State website and where you would apply on Connecticut, as well as the New York State Department of Health. Because some of you live right on the border, just as I did. I went to school in Connecticut, but I actually practiced in New York, and I knew I was going to be working. I was hopeful to be working in both contract. So when I graduated, I went ahead and applied right away for both my Connecticut and New York State APRN license. You only have to be certified in one, once through either the ANCC or AANPCB. But just keep in mind, if you wanted to become licensed in New York, you also have to hold your RN license in New York as well, just as you do in Connecticut. So in order to get your licensure as an APRN in Connecticut and New York, you have to hold your RN license within the state. So, and that's going forward always. So in order to keep your APRN license active, you also need to keep your RN license active in Connecticut and in New York if you're going to have the New York licensure as well. So just keep that in mind. It's an extra fee, obviously. You have to keep both in order to maintain your APRN license. There are fees with your licensure. There is a fee with your certification. This stuff does add up. So just make sure you pay attention to those fees so you're prepared for that. It's interesting, just so as a side note, I'm also licensed in Florida. And the interesting thing that's different about Florida State is you do have to be licensed as an RN, but it doesn't have to be licensure from Florida. So my New York license and my Connecticut license as an RN was enough to allow me to get my licensure as an APRN in Florida. So even though I'm not licensed as an RN in Florida, I'm licensed as an RN in New York and Connecticut. So that was valid enough for them to give me my licensure in Florida. It's interesting. Also, keep in mind timeframes. You want to start getting applied as soon as you can for these particular things, because every state takes a different amount of time, and it's no rhyme or reason. Sometimes your documents are not 100%, so they hold things up from that. Sometimes it's just sheer volume in terms of the amount of APRNs that are in the process of applying. So the state board is just going through each person, and it's just taking time. I know when I applied for my Connecticut state license, it took about 6 weeks to get that. It came through. In terms of 6 weeks time-wise, I mean, like 6 weeks after I graduated. Like right after I graduated, I took my certification exam through ANCC. Within a month, I took it. Just as a side note too, before you take your certification exam, you may want to consider taking a review course, which is what I did. I took the LEAP review course right online. They were only offering it online at the time because of COVID. I took my LEAP review course, then I took my certification exam, then I went and applied for my license, okay? All of my license. So I applied for my Connecticut license first. That took 6 weeks to come through. My New York State license took 6 months. Interestingly enough, when I applied for my Florida license, it took 5 days. So it's just a matter of, there really is no rhyme or reason. Even my boss was in the process of trying to apply for his Florida license, and he's out of Maryland. His original licensure is out of Maryland, and it had taken him over 7 months to get his approved. So, just go ahead and make sure that you're putting things in as quickly as you can so that you can start working as soon as you can. Okay, so you've applied for your licensure, you've now been approved, you've gotten your license in Connecticut or New York or wherever you're getting your license. Now it's time to apply for your NPI number and your DEA number. Some of you may already have an NPI number, which you have through your RN, which is fine. Once you get your APRN license, then you can go ahead and update that in their NPI system. The website is listed there. And then, of course, you're going to apply for your DEA number, and this is so you can prescribe controlled substances. Okay, and again, that is a big fee. I think it's about $1,000 to get that licensure. So, and it also takes time. There's a lot of background checks and what have you. Keep in mind, you don't have to have your DEA number. Not every place of employment requires that. So just consider that before you start spending an extensive amount of money. You can still prescribe. Keep that in mind. You don't need your DEA number to prescribe in Connecticut. You do need it to prescribe controlled substances, but besides that, you can still prescribe. Another thing to consider is, just as a side note, if you are applying in New York State for your licensure, there is an extra additional, I think, 2-hour pharmacy course that you need to take because they have a few other things you need to know in New York that's different than Connecticut, that they have people who have been educated outside of New York take. So just keep that in mind as well, because it does slow down the process as well. All right, guys, all of these websites and things are listed on module 1, I'm sorry, in Canvas. So please bookmark all of these websites because you will need them for future reference. Now, I don't want you to get overwhelmed. I just wanted to make sure you have kind of a little picture of what the journey looks like once you graduate. All right, we will be going over this again once you get closer to graduation and helping you step by step as things come up. But I just wanted to make you aware of how this all kind of comes together at the end. It is in terms of professional licensure. All right, guys. So don't think this is easy to get to this point. Obviously, there's a lot of steps to becoming an NP, and you know, you're getting just the basic skeleton view of it. And again, just so you're very clear, there are a lot of fees involved, both at processing when you first get your license and as the years go on in terms of maintaining it, both for liability and licensure and registration. Okay, so you'll be, the states that you are licensed in will email you when things are due, and you will have sign-in online logins for both of these websites. So you'll always be able to go in and check on the status of your licensure. Okay, knowledge check, just a few review questions to go over what we went over last week. Here's a question. Nurse practitioners and clinical nurse specialists derive their legal right to practice from A, the Nurse Practice Act in the state where they practice, B, the laws of the state where they practice, C, the Medicare statute, or D, the Board of Nursing in the state where they practice. This is a little bit of a tricky question. Please make sure you read this and then let's review. The correct answer is A, the Nurse Practice Act in the state where they practice. Remember, the Nurse Practice Act is a statute enacted by the legislature of each individual state. The act delineates the legal scope of practice of nursing within the geographic boundaries of the jurisdiction, meaning within the state. The purpose of the act is to protect the public. The SBON, also known as the State Board of Nursing, and just so you know, guys, there's a lot of initials used throughout textbooks, reference books, review books. I always, in my PowerPoints, try to spell out the initials, because I used to find when I was a student that would get me so confused, because there's so many initials for so many different governing bodies, that I always try to spell it out just as a reminder when you're reviewing things, so you don't get confused. Okay, so anyway, so the SBON, or the State Board of Nursing, is the agency that enforces the Nurse Practice Act. And just so you don't get confused, keep in mind the Medicare statute provides the funds for paying for healthcare services of people over the age of 65. All right, we'll go over Medicare and Medicaid in just a few minutes. Okay, another question to review. Which is a true statement regarding claims-based malpractice insurance policy? So remember, we went over the two different types of insurance policies, occurrence-based and claims-based. So this one is asking about claims-based. Now, just so I can remember to remind you, when it comes to reading questions, remember, test taking is something you're going to have to remember how to little tips for test taking. I wanted just to remind you, make sure you're reading the question. So in this particular question, when I read it in the text, it was not underlined claims-based, but I underlined it because I just wanted to make sure when you're reading this question, you're really thinking about claims-based as opposed to occurrence-based, okay? So which is the true statement regarding claims-based malpractice insurance policies? A, if the insurance company's lawyer finds the NP negligent, it is the nurse's responsibility to pay for the claim. B, claims against the NP are covered as long as the nurse had an active malpractice policy at the time of the incident. C, claims against the NP are usually paid if the nurse is found not to be negligent. Or D, claims against the NP are covered if both the incident and claim happen when the policy is still active. And the correct answer is D. The true statement regarding claims-based malpractice insurance policies are that the claims against the NP are covered if both the incident and claim happen when the policy is still active. Keep in mind, when the NP stops paying for the premiums for this type of policy, it is no longer active and she is no longer covered. Okay, one more question for review from last week. All of the following statements are correct regarding licensure for NPs except, okay, again, I highlighted and italicized except, because again, I just wanted to reiterate with you guys, they're not going to do this on exams or on the boards, but I wanted to remind you, make sure you're reading the question correctly, all right? So all of the following statements are correct regarding licensure for NPs, except A, it ensures a minimum level of professional competency. B, it grants permission for an individual to practice in a profession. C, it requires verification of educational training from an accredited graduate program. Or D, it reviews information via a non-governmental agency. So the correct answer is D. All of the following statements are correct regarding licensure for NPs, except it reviews information via non-governmental agency. Okay, that's not true. The State Board of Nursing is a regulatory agency created by the state government and is devoted to monitoring nurses' personal and professional behaviors. State Board of Nursing have the legislative power to initiate, regulate, and enforce provisions of the Nurse Practice Act. Okay, I just want to make a little point here. Personal and professional behavior. State Board of Nursing are devoted to and regulated to monitor personal and professional behaviors. Keep that in mind when you are using your social media. Okay, guys, just be very conscientious. You are moving into a professional role. As a nurse practitioner, you are held at a higher level of liability and responsibility and professional behavior. So please be very conscientious about what you are posting on your social media. All right, guys. Okay, getting into chapter 80. So the business of advanced practice nursing. So here we go. All right, so overview of today's healthcare system in crisis. All right, so obviously our healthcare system has been struggling for a bit. Obviously costs continue to rise. Insurance carriers are struggling to contain cost and control access. And there is a lot going on in the legislation and politics in terms of healthcare reform. We are at, decades of a struggle and debate, and everyone in the world obviously agrees that reform is needed. So one of the things we need to look at is the APRN's role in containing cost. What is our role? Okay. So the first thing I just wanted to point out before we continue on in terms of the APRN role, another thing that they reviewed, I was reviewed in my graduate program, they reviewed with us that I found very helpful because again, when I was starting my journey as a nurse practitioner, APRN school, whatever you want to call it, I was getting confused because everybody kept talking about APRNs versus NPs versus CNS, like what does this all mean? What is what? So just keep in mind the terminology advanced practice nurse is kind of an umbrella term for different types of advanced nurses. So we have different types of advanced nurses, and here are the four main subspecialties of the APRN. We have the nurse practitioner, which is the role you guys are in. Now keep in mind, there are different types of nurse practitioners. Your particular program is the FNP program, or family nurse practitioner, right? My particular program that I went to was adult gerontological primary care nurse practitioner. That is my specialty. There also is the nurse anesthetist specialty, the nurse midwife specialty, and the clinical nurse specialist. Now keep in mind, clinical nurse specialists are APRNs, but they are not NPs. So just make sure you're differentiating these different things because we all have different scopes of practice. Clinical nurse specialists have advanced degrees that specialize in a specific area of nursing, okay, such as geriatrics, pediatrics, disease subspecialties, or types of care. Nurse midwives care obviously for patients during pregnancy and after childbirth, and they are usually associated with home births, and they routinely practice in hospitals, clinics, and birthing centers. And then of course you have your certified registered nurse anesthetist, and then you have your nurse practitioners. So just keep that in mind. APRN is just an umbrella term for a specific type of whatever, NP, nurse anesthetist, so you want to always differentiate when you're speaking to an APRN, what is your specialty? You can always ask it like that. Now, that being said, different states call their APRNs different things. So it's interesting, in New York, you're known as a nurse practitioner. In Connecticut, you're known as an APRN. Like that's what your actual little license that they send you says. In Florida, I'm called a certified registered, they call us CRNPs in Florida. So it's a certified registered nurse practitioner. It's, and it's all the same thing. The credentials are what they are. So they hold the same meaning. Also interesting point to point out in this, when I applied in Connecticut, out of my school, our program specifically was called the Adult Gerontological Primary Care Nurse Practitioner Program, right? So my initials technically are adult so my initials after my certification are Adult AG PNP, Adult Gerontology Primary Care NP. So I have a lot of initials behind my name, but when I go to apply in New York for my license, they don't have adult gerontological primary care NP. They either have adult NP or they have gerontological NP. They don't have both in terms of one certification or one licensure. So I went ahead and applied for both because I figured I needed both, but they actually ended up returning one of them and said you only need one because it covers adult and gerontological licensure. So again, just be aware of what your particular school and licensure says in terms of your title. All right, just to clarify that. So again, APRN is an umbrella term, and then there's specific nurse practitioner types and clinical nurse specialists that fall under the APRN specialty. Okay, so back to the overview of today's healthcare system, the system in crisis. So there's a patchwork of regulation that's going on where obviously as our legislation is always, striving to help things become more streamlined. They're trying to reduce administration costs related to the healthcare system. And, becoming an APRN, you're actually going to have a unique opportunity to help in restructuring healthcare and containing costs. I know my role that I do right now, I'm working as a wound consultant. I travel across all over the United States in terms of practice. I've done consulting in all kinds of different healthcare facilities, rehab facilities, short-term care facilities all over the country. And one of the biggest things that I can see that my role has been in terms of containing costs is working with our wound care rep companies, or wound care supplier companies, and really working with them closely, even when I do rounds, to make sure we're containing costs, because these wound care products cost so much money and they really are not utilized effectively in the facility. So one of the roles I find myself really making sure I'm working with all of the staff is on cutting costs, because facilities end up paying for the wound care supplies if the insurances deny their claims. Okay, so third-party payer rules. So what does this even mean? So keep in mind, there are different categories of third-party payers. Each payer source has its own policies and fee schedules, and all of them use the guidelines provided by the CMS, the federal agency that runs the Medicare program and Medicaid, okay? So no matter if you're employed by a hospital, a private practice, a community health center, or if you're self-employed, the third-party payer most often determines the reimbursement policies. So you need to know who these third-party payers are and what they cover. All right, so important, because keep in mind, to deliver your effective healthcare, you need to know and be able to assist your patients in understanding what their insurance will cover and what they won't cover. Okay, so here I wanted to just put up a few images to really make sure that you're understanding and differentiating what Medicare covers. There are different parts of Medicare. It's really important for you to understand how the patient themselves decide to get their coverage and how they pick it. And in order to understand that, you need to understand what each part covers. So for instance, Part A, Medicare covers inpatient hospital stay, skilled nursing care, hospice, and home care. Part B covers your doctor's visits, surgery, lab tests, medical equipment, and preventative exams. Part C is similar to Parts A and B with predictable out-of-pocket costs and coverage. And they have often will fully cover wellness, vision, and hearing, and partially covers eyes and hearing aids. And then you have Part D, which also is private insurer and health plans, which is a kind of a prescription drug program that's not covered by the original Medicare. It's optional for the patient, but it does give them a little respite from their prescription drugs and how much they have to pay out of pocket for that. So that's in terms of what Medicare covers. Here's what Medicaid covers. Remember, Medicaid is covering low-income families, individuals with disabilities, and elderly individuals. Keep in mind with Medicare, remember, we're talking about patients that are 65 and up. Okay, Medicaid, it's not based on the age, it's based on income, disability, and elderly individuals specifically who need to go into an institution. Okay, Centers for Medicare and Medicaid Services, or CMS providers, all right? Medicare providers agree to practice healthcare delivery according to the CMS guidelines, and CMS payment is published yearly in the physician and non-physician provider fee schedule. So they basically dictate how much everybody's gonna get paid depending on what's going on with the patient, okay? Here, you need to realize too, as when you're in practice, the next thing you're gonna need in order to bill as a Medicare provider, you need your NPI number. So again, make sure you go back to that module 1, look at that reference for the NPI. When you are ready to apply for your NPI number, you will need that, okay? What else did I want to say? Okay, so just keep in mind too, each state's board of nursing and legislation sets the policies and guidelines related to the level of medical supervision and oversight, as well as prescription authority granted to APRNs. Okay, so we know that. We were just talking about how the State Board of Nursing sets the guidelines. So guidelines detailing the APRN requirements for licensure and certification should be reviewed. So I posted those sites on module 1 so you can review what it's entailed in your licensure requirements. Again, they differ state by state. And keep in mind, Medicaid patients face reduced access to care, and payment is generally 85% of Medicare payment. So what exactly does that mean? That means your Medicaid patients, you're going to get paid less than your Medicare patients. And this is something you may already be well aware of, because I'm sure in your institutions, just like in the institutions I go in, the liaisons who are trying to get referrals to get patients into facilities or home care referrals or whatever, it doesn't matter. They're always looking for those Medicare patients because those are the ones that get reimbursed the most. And, it's unfortunate, right? We're in a world of business of taking care of human beings. But unfortunately, the reality of it is everybody needs to get paid. Your company needs to get paid. You need to get paid. The insurance company needs to get paid. Everybody wants to get paid. So the reality of it is you're going to be coming in contact with this billing and coding literally every single day with every single patient you practice with. And that's why I felt it was so important to go over this in class, because it's literally something you're going to be dealing with on a daily basis in your practice. So for every single patient I see, no matter if it's 30 patients, 70 patients in a day, I have to make sure I code and bill appropriately, okay? Because otherwise we don't get paid, and that's a problem. Okay, so again, we have our CMS, or Centers for Medicare and Medicaid Services providers. So Medicaid payments rely on joint funding from the state and federal governments. So keep in mind, claims are often adjudicated through a managed care contract, and Medicaid expansions through PPACA are offered to those states that participate in the exchange and cause challenges to those in states that do not participate. Okay, so we're going to get into that in a little bit. Hold on. So in order to really understand what they're talking about here, I just wanted to review again, what is the Affordable Care Act? Okay, so keep in mind that the National Health Insurance Legislation, also officially known as the Patient Protection and Affordable Care Act, or the ACAA. So don't get that confused. PPACA and the ACA, they're the same things, because they kind of changed the names as time has gone on, but it's unofficially named Obamacare. Okay, so it's all the same thing. We're talking about the Affordable Care Act, which was signed by President Obama in March of 2010. And remember, the goal of the Affordable Care Act was to expand health insurance for the millions of Americans who were at the time uninsured. All right. It expanded healthcare coverage through various provisions, allowing adult children younger than age 26 to be insured under their parents. This comprehensive reform of US health insurance law prohibits an insurance company from rejecting people with pre-existing health conditions. All right. There is also a penalty for employers and individuals who choose not to participate in the national health plan. Although increased numbers of Americans gained insurance as a result of the law's passage, many millions still lack the coverage. Okay. So that's just something important to know. Make yourself just knowledgeable on the Affordable Care Act and the good and bad things that have come out of it. Okay. So again, don't get confused with these initials, PPACA or ACA, Affordable Care Act, all known as Obamacare. Okay. So PPOs and HMOs. So PPOs and HMOs. So what are HMOs? HMO stands for, so keep in mind in terms of managed care, okay? Both health maintenance organizations or HMOs and preferred provider organizations or PPOs are classified as managed healthcare plans. So we have PPOs and HMOs. Those are our managed care plans, okay? So HMOs or health maintenance organizations, this is where patients are assigned a primary care provider who is the gatekeeper, and then the patient has a set copay per visit, and the participating healthcare provider is paid a set fee per patient monthly. The physician receives a monthly check from the HMO. So with HMOs, the PCP must first approve referrals. So the patient is limited to seeing the physicians and specialists who are enrolled in only the HMO's network. If they go to out of network, the visit may not be covered or it will be reimbursed at a lower rate. Versus our PPOs. PPOs, the patient can visit any provider in the network without a referral. They do not have an assigned PCP as they do in HMOs, and they can choose their own PCP. No referral is needed to see a specialist who is part of a PPO panel. And of course, because they have less restrictions than the HMOs, PPOs are usually more expensive than the HMOs. So PPOs, HMOs are both your managed care companies. PPOs, you can go to whoever you want, and HMOs, you're assigned your primary care provider, and they basically call the shots as to who you go to, depending on what your needs are. The PPO is more expensive. So that's the real basics of what you need to make sure you're understanding in terms of PPO and HMO. Now, why is this all important? When you get your patient list when you start your rounds or you're getting your schedule for the day, guaranteed next to each of your patient's name, you're going to see what kind of insurance is listed. That is so important for you to acknowledge and be aware of, because you're going to need to know, do I need to give them a referral, or can they pick whoever they want? Is this drug going to be covered by their formulary, or am I going to have to write a generic or pick a different drug? There's a lot of factors that come into play in terms of insurance. Is this patient going to be eligible for going into short-term rehab? How many days do they have left from their last bout with short-term rehab? There's a lot of factors involved. So just be aware, you need to know what the different insurance companies are, what they cover, and what your patient is willing and able to pay for out of pocket. Keep in mind, these are conversations also you're going to want to have with your patient. You want them to be honest with you so you can be honest with them, and you can really just come up with the best plan of care for them that's going to be reasonable and they're actually going to be able to follow through with in terms of their financial abilities. Okay, so HMOs, health maintenance organizations, like we said, historically generally involved a gatekeeper model directing care access, but this label fell off out of public favor. Even though the term is no longer used, most plans function under HMO legal rules. Okay, so again, HMOs, your primary care physician is assigned to you, and then they kind of call the shots, or AKA are the gatekeeper of the patient's care. So non-contracted patients and beneficiary education. So patients who have insurance but seek services from a provider that is not contracted with their plan. So those are non-contracted patients. Understanding and following insurance plan benefits and rules is essential. So beneficiary education in terms of you being the nurse practitioner and really understanding what the insurance plans cover. And carriers are increasingly providing education and information to support good healthcare choices. So keep in mind a couple of things. This seems like a lot of information you're suddenly going to have to learn, and rules and regulations of each insurance company. That seems excessive. Like, how am I going to remember all this? Okay, keep in mind for each particular practice or place you're working, the likelihood is they're going to give you a lot of cheat sheets. They're going to be giving you tutorials, in services, and kind of guides, as well as cheat sheets, to give you an understanding of what exactly the main things are that are covered or not covered, and coding as well. They're going to give you a cheat sheet in terms of the most commonly used codes. Believe me, your company, your business you work for, the practice you go into, they want to get paid as well. So they're going to try to make it as easy for their APRNs as possible. If it's a good place you're going into, side note, but they're going to try to make it as easy as possible for you to know, what codes to use and when to use them and how to use them. So for instance, in my company, our big thing is, one of the big things we're always looking at is cost, of course, in our wound care supplies. So of course, I have a book of cheat sheets in terms of what's covered, what's not covered, what insurance company covers this, what insurance company covers that. So I always have that on me, so I have a quick reference tool. You will most likely be provided with those reference tools in your job, and you will probably end up creating your own as you go along. I've created my own little reference tool for myself of things that I find I'm constantly referencing or using on my day-to-day practice. So in terms of beneficiary education, it's not just for you to know, but it's also for you to know so you can educate your patients. As a provider, you want to inform your patient if they are not contracted on your benefit plan. Keep in mind, HMO patients in an acute care hospital setting are guaranteed treatment, and the non-contracted providers are required to accept the HMO determined payment. In the office or outpatient setting, the patient seeking services would be responsible for provider billed payment. This patient may wish to negotiate a payment rate with a non-contracted provider. So sometimes you'll hear non-contracted providers have like a sliding scale fee that they'll work with patients. It all depends on the provider, but the patient should be made aware very right up front what the expectation is in terms of billing. Okay, so again, I just wanted to review in terms of the Affordable Care Act. Like, don't get confused with all the initials, Affordable Care Act or the Patient Protection and Affordable Care Act. It's all the same thing. We're talking about Obamacare, all right? Okay. So we want to make sure in terms of the, just to review the Obamacare or patient, let's review again, Patient Protection and Affordable Care Act, the PPACCA, there it is at top. We want to make sure that that we understand that the objective of Obamacare was that they were payment aligning with outcomes and value of services, that, it was never about volume. However, that has changed over time, but irregardless, we wanted to also change that patients would still be covered despite having a pre-existing condition. We wanted to remove the lifetime cap on coverage. We wanted to make young adults under the age of 26 covered under their parents. Obamacare also tried to develop new federal insurance market rules that would establish essential standard benefit packages, which would hopefully help just navigate things a little better for specific disease processes. And it also, was striving to limit charges for administration and profits, just to help cut costs. Now, has it done all that? In some aspects it has. It's nothing is perfect at this point, that's for sure. So it also offered opportunities for small business co-op options. It was trying to eliminate the donut hole in Medicare drug coverage. It wanted to help with long-term financing programs for the disabled. It was trying to invest in a stronger primary care foundation, and it also developed an innovation center within the CMS. They created the Independent Payment Advisory Board. They invested in an infrastructure that offers publicly reported information. It definitely incorporated the nurse practitioner's role in the ACA. They brought in the NPs specifically to help in these particular areas. The goal was also to ensure the uninsured and, create more technologies and infrastructure to help with all of this. Okay. Another big thing we need to talk about in terms of business essentials, as a nurse practitioner, part of the reason, the benefit of becoming an NP was that you can practice independently as eventually, depending on which state you are in, depending on their regulations, at some point you will be able to practice independently. Specifically Connecticut, New York, there's a certain amount of hours. For New York, it was 3,600 hours before you can practice independently, although that's when I graduated. Now that has changed. Those laws are changing as time goes on. But in the meantime, the likelihood is some of you may at some point decide that you want to practice independently because you don't want to follow the rules of institutions or be answering to anybody, and you have developed your skills enough that you feel that you're competent enough that you can practice independently. So in this case, you still need to know the business essentials in order to keep your business flowing and producing enough income to sustain you and keep you financially happy. So what are the business essentials we need to talk about? Obviously, like any business, you need to remember the importance of maintaining cash flow, the importance of monitoring and obtaining payment for services, and keeping an eye on accounts receivables, meaning keeping an eye that people are actually paying their bills. Okay, so how many of you have gone for medical services and just let that bill slide for an extended period of time? Well, you don't want that to happen in your practice. So how do we keep an eye on accounts receivables? That's what we're going to get into. The reason that we're talking so much about coding and billing is not only for your practice when you're working under a business, but if you were to practice independently, you yourself need to make sure that you know how to code and you know how to bill so that you yourself can get paid. Okay, it's not just about for the company you work for. If you have your own company, you want to make sure you're getting paid the max amount. So in terms of business essentials, we want to make sure we're developing a sound and effective collection policy. So you want to make sure you have a policy written for your business and for your patients, so they are clearly know when the bill is due, what the expectation is, what the repercussions are going to be if they don't pay their bill. We want to make sure you're controlling practice costs and managing overhead expenses. You want to watch financial statements to ensure that your outcomes are where they should be in terms of your financial goals for your business. And you want to use your budget to gain financial success. So you want to create a budget for your practice before you walk into it. So realistically, guys, you're not getting a business degree here, but you do have to understand that if you want to open your own business as an APRN, you need to understand all of these things and specifically understand the importance of coding and billing. Okay, so contract and carriers' impact on cash. Knowing that payment is not guaranteed based on solely delivering the service. Okay, so what does this mean? So contract carrier rules. What we have listed under the rules are the levels of service based on presenting problem and symptom. Note multiple unrelated services in the same day reductions. Review formulary for medication, ensure complete documentation, and review contract language. Okay, and then accounts receivables, things to consider are unclean claims. Electronic billing is required and facilitates quicker payments as well as edits by the carriers. Payment posting, if manual, affects cash flow. So where's your payment going? Is a check being mailed to you? Is the check going direct deposit? Like how are you getting your money? Billing denials and reduced payments. So these are all the different factors that can come into play. It's not like, oh, the patient came in, I billed him, he paid, done. The transaction is over. No. First, the patient comes in, then we bill the insurance company, then we have to figure out how much the insurance company paid, and then what is the patient's responsibility. Then we have to notify the patient, bill the patient has to somehow at some point write the check and mail it back to us. Okay, that's a lot of time before we actually get paid. So those are things you need to consider. So keep in mind, unclean claims, which are billed late, and what are unclean claims mean exactly? So those are bills that are billed late. Maybe all fields in the bill that you're putting in are not completed. There was an error in the entry. The request for documentation by the insurance company was not sent back in a timely manner. So the insurance company just dropped it. And then you don't get paid at all. So you need to know what the carrier's rules are that you're working with, okay, what your contracts are with each insurance company, okay? Account receivables include the billing denials and underpayment on claim services, which require constant monitoring and research to obtain a contracted payment date. So you may want to consider specifically hiring a coding and billing auditor for your specific practice. Now, keep in mind, in any of the places that I've ever worked, whether it was as an RN or an APRN, we have auditors. We have, in my current company, I get literally emails probably every couple of days on different charts they have audited before they're even bothering to submit them to the insurance company, with things that need to be fixed or clearly documented or added documentation, or I needed to change my codes because I accidentally coded on a new patient that was already an established patient. All of these things slow down billing. So there are things you need to keep in mind when you yourself have your own practice or when you're working in a practice. So keep in mind, many carriers develop their own company specific rules, and it's all based on whatever they come up with in their contract. So contract negotiation is the time to review high volume services to ensure payment covers our costs. Payments are actually covered. Okay, so setting fees and collection policies. So carriers pay the lesser of fees or charges, and then collecting patient co-pay and deductible before services enhances the ability to gain payment, supports enhanced patient understanding of payment responsibilities, and decreases administrative costs. So obviously, if you collect the patient's copay and deductible like when they arrive, that's your best bet. If you're going to bill them afterwards, like it's going to take time. There's always room for delay. There's always reasons that the patient could forego paying that bill so they could pay a different bill. There's a lot to it. And in terms of decreasing administrative costs, well, if the patient's payment is collected at the time of service, then guess what? You don't have to spend any money on your secretaries or anybody else calling and hounding this patient and spending time, wasted time just trying to get them to pay their bill if they paid it right away. So those are things to keep in mind. You're going to have to kind of be tough when it comes to getting payment, because otherwise, forget it. It's just going to be like a never-ending issue. Okay, now we're getting into reimbursement rules. So obviously, understanding and getting knowledge on the rules enhances your optimum payment. So this is where we're going to get into CPT coding rules, unlisted codes, modifiers, and add-ons. This is not that difficult. Please don't get overwhelmed with it. The bottom line is there's a systematic way of approaching this. I'm going to show you how to do it. Just keep it basic in your head. The beautiful thing is there's plenty of guides and reference tools in terms of actual CPT codes. You don't have to memorize codes or learn codes. You just need to understand how to apply these codes to your documentation, okay? And how these codes affect your billing. That's the biggest thing you need to really understand about all this. Okay, so again, obviously, knowledge of the rules enhances optimum payment. So that's what we're all about here. We want to understand the rules so we can get paid as much as possible, right? All right, so collaboration. So again, keep in mind, depending on what state you're licensed in, you may need a collaborative agreement with your physician, with a cooperating physician, in order to practice, because certain states require a certain amount of hours for you to practice as an APRN under a physician before you're allowed to practice independently. Like I said, when I first applied for my license, when I graduated in New York, there was a 3,600 hour requirement for me to work with under a collaborative agreement with a physician before I'm allowed to practice independently. So the first job I got as a nurse practitioner, when I was hired, immediately the job itself sent me a collaborative agreement. They have a physician that collaborates with all the NPs that work with them, and they signed an agreement with me that he would work with me and make sure that he was collaborating with me so that I could practice in this particular business. Now, keep in mind, the collaborating physician doesn't have to be on site. This physician literally would call me every few weeks in the beginning, checked in, we talked about a few cases, he reviewed my charts, and he gave me, and we collaborated. That's exactly what it is. It's a collaborative agreement. He spoke to me with respect, gave me a lot of feedback. He was wonderful, my first collaborating physician. And then as time went on, I would hear from him once every 3 months. I could always reach out to him if I needed to. If I didn't need to, it was just simply a check-in. But that is what the agreement stated, that we would check in every so often and we would collaborate as needed. Okay, so that's part of one of the things in terms of payment. If you're, out of your scope of practice and you're not working with a collaborative agreement and you're supposed to based on your state licensure requirements, then the likelihood is you're not going to get paid. Okay, then we have our CPT level 2 codes. Just in terms of just CP2 codes, we'll get to that. So just know these are the different rules that you're going to need to be aware of in terms of payment. So you need to know your CPT codes. You need to make sure you have your collaboration agreement with your physician if it's necessary in your state. You need to make sure you know your Medicare physician and non-physician practitioner fee schedule in terms of the timing of putting things in. And when you're going to be able to get reimbursed. There are deadlines. So you can't bill out like for something that you did 5 years ago. You know what I mean? There's deadlines with certain things. So make sure you're aware of that. You want to make sure you have your evaluation and management documentation and your electronic medical record. Okay, and basically all that means is know what system you're using in your particular job and know how their coding system works. The other interesting thing I wanted to point out was in terms of your EMR, your electronic medical record, every single place I've gone to, every different place I've worked at, every place I've consulted with, even when I was in my clinicals at Danbury Hospital, everybody has a different way of billing. Okay, so example, I did my clinical rotations at Danbury Hospital in pain management. And the interesting thing was those nurse practitioners have an app on their work phone that they're provided with by Danbury Hospital. And for each patient, they go into their little software app and they code as they're doing right after they finish their visit. So they immediately mentally take note of, certain factors in their visit, and they immediately know how to code, and they code right when they walk out the door. Because one of the biggest things that they know is important, besides just their documentation and following through with their care plan for their particular patient, is making sure they code for that particular visit. Because again, no codes, no payments. And that's not going to work for anybody in your business. Okay, so just make sure you're aware of what your particular practice expects in terms of coding and how quickly they need that information into your charting. For me, in my practice, that needs to be in before the end of the day. And it needs to be locked and submitted. And if it's not, there's big trouble. I'm getting a lot of emails from the CFO and CEO, that's for sure. Okay, so CPT code, CPT modifiers, and add-on codes. So what does a CPT code even stand for? Okay, common procedural terminology. Okay, so that's all it stands for. Again, all these initials, it gets a little confusing. Don't let it overwhelm you. All it stands for is common procedural terminology. Okay, so CPT codes, and that's just a generalized term, and they're updated yearly by CMS, or Center for Medicare Services, yearly to provide a code reference used to uniformly document current care. I'm sure all of you have experienced coding in your RN role at some level, but as an APRN, now it's a whole different story. Now you are in charge of coding, and keep in mind, you now can diagnose, right? So once you graduate, you can diagnose. So now it's up to you to make that diagnosis, justify it through your H&P review of systems documentation, and then go ahead and put in that CPT code. Like, it was such a game changer for me when I started documenting and realizing, I would say, oh, I think he has this. And then I would go confirm it with my boss. And he's like, yeah, he does have that. And you just diagnosed him and you need to put that in. And I'm like, oh my God, I'm an NP. I can do that now. Like, how liberating. So it's pretty cool. I mean, it's a lot of information to have to be know and be responsible for, but it's still quite liberating to know, wow, I just, realized something and I can actually put it in the system and it's actually a valid thing. It's really nice to feel that, in the very beginning when you start practicing. Okay, so ICD codes evolved to ICD 10 codes. So as the CMS is updated every year, they change the number, just so you know, the new codes are now you're going to be referring to as the ICD 10. So it used to be the ICD 9, now it's the ICD 10, and that will change as updates occur. So they're not updated that often. The most I think the most recent update occurred in here on this PowerPoint, it says 2015. I'm pretty sure that's the most recent. In your module, I also uploaded a bunch of CMS, ICD reference tools and different websites you can go to look up codes. So you're going to find sometimes during practice that you're Googling looking for codes because you have no idea, like you don't know. So another side note to keep in mind in terms of looking up stuff on Google and referencing stuff, try to make sure whatever website you're referencing from, obviously you want to make sure it's valid. And usually your best bet is to go with websites that are .gov or .org. Okay, those are going to be your, your real valid and evidence-based websites. Okay. So again, the updates occurred in 2015. That's when they became ICD-10 codes, and the codes are used to report patient diagnosis and supports the billed level of care. Okay, I'm going to repeat that again, just so we can get a very basic understanding of what these codes do. ICD-10 codes are used to report patient diagnosis and supports the billed level of care. Now, how does it support the billed level of care? Based on your documentation that will support the code. Okay, so coding is not just about putting in a number and saying, okay, this is what the patient has, here's what I'm going to bill for, here's the code. No, you need the code and you need your H&P, your review of systems, and your all to be reflected in your documentation to support those codes. Okay, so keep in mind ICD-10 changes, they're larger and more specific listing of codes. So in terms of the difference between the ICD-9 and now the ICD-10 codes, what they're saying is the changes that happened in 2015, basically they're just saying there's more codes. So, that's what happens when you make changes and you add things. There's obviously going to be more codes. So now there's 3 volumes versus 2 volumes of codes. You have the alphanumeric format versus numeric only code categories. They probably had to do that because, again, they increased the amount of codes. They reorganize certain conditions, and there's minor changes related to mortality-related events. So whenever there are ICD-10 changes or ICD code changes in general, this CMS, they put out a notification. So you'll be made sure to be privy to whatever changes are being made. Oh, one other thing. So just keep in mind, hospitals use ICD codes for procedures as well, and these codes support the CPT payment and substantiate the level of care that is prescribed for the presenting patient. So of course, hospitals have their own codes as well. Okay, so we want to review the basic steps of coding. How do we code? Where do we even start? There again is a structured way of doing this, and we're just going to I'm going to keep it very basic in this particular PowerPoint because I really want you to just understand the basics of why we're doing it and how to basically do it. So first things first, review the health record. Obviously, you're going to review your patient's chart, okay? Keep in mind that a lot of the times when you review the patient's healthcare record, there's already going to be a gazillion diagnoses codes listed. So you want to look at those codes. You want to see what your patient has already been diagnosed with. Now, these word of coding, just keep in mind coding. The codes are the diagnoses. So the beautiful thing is when you're looking at these codes or diagnoses that are already listed and procedure codes that are already listed under your patient, you're getting a beautiful synopsis of what's going on with your patient. Okay, so I'm looking at the 10 different codes my patient has. He's got a diagnosis code for hypertension, a diagnosis code for obesity, a diagnosis code for peripheral vascular disease, a diagnosis code for COPD, a diagnosis code for anemia. Okay, I've got 5 codes right there that all I know right away. This is putting my patient at extremely high risk for, skin breakdown. Right? So already right there, I have 5 codes already in the patient's record that I can substantiate in my documentation to show why I'm even walking in the door to assess this patient's skin. Okay, because this patient is already high risk for skin breakdown. All right. So that's a beautiful thing about these codes is it gives you a standardized view of your patient before you even walk through the door. So either they're in the health record and you're reviewing them, or now you have to consider putting in your own codes based on what you're observing and what you're about to do. Okay, so we reviewed the patient's health record, reviewed the patient's chart, looked at their discharge summary, reviewed what diagnosis and codes they already have listed under from the previous encounter or during this current encounter, whatever. You're going to review the emergency room documentation for whatever diagnosis or code got them admitted to the hospital. Okay, that's important because again, we're going to refer back to that code, aka diagnoses, when we go in and document our H&P if we need to. And then we're going to, after we've reviewed the healthcare record or the chart, we're going to identify the diagnoses and procedures to be coded. So again, we want to review all the progress notes, operative notes, anesthesiology notes, and consults to arrive at all diagnoses and procedures that need to be captured or reported. And again, you want to make sure, like whatever you're going to be coding, that you can justify with your own documentation. So that's how we start. So we reviewed our record. We're identifying diagnoses and procedures that need to be coded. Okay. Then we're looking, we're going to we're going to review the admitting diagnoses. We're going to review differential diagnoses. Okay.
It's 2 o'clock.
In terms of the admitting diagnosis, you're looking at the condition that was responsible for the patient actually being hospitalized. And it may be a sign or symptom that requires testing and evaluation to determine a diagnosis. We're going to look at the differential diagnoses. What other possible things or possible diagnoses could be presenting here based on these current symptoms? And then we're going to consider the secondary diagnoses or other diagnoses that affect patient care because they require clinical evaluation, therapeutic treatment, or extended length of hospital stay, which increases nursing care or monitoring. Okay. Okay, then we're going to locate the main term in the index to diseases. Okay, so these slides in terms of understanding the basic steps of coding actually came from our coding class. All right, so I asked, Professor Alana actually provided these from a coding class. So she asked me to put these in our presentation. This goes really into the actual coding itself. Keep in mind, you know, in terms of locating the main term and the index to diseases and identifying the bold subtype, this is specifically for people who are actually coding for a job. You're going to have a reference tool, whether it's provided by your job or something you create or something you find on the CMS website, that's going to give you specific indexes to codes that are going to be relevant to your particular practice. So you're going to go into your little reference toolbox, look at the current codes based on the diagnosis you're looking at, and then you're going to use that code. Okay. Now, codes can be broken down based on the body types, the diagnoses. There's all different codes. So again, look at your reference tools. Okay, whether it's the alphabetical index in the CMS guidelines, or it's your reference tool that your job provides for you, whatever it is, just make sure you break down your code if necessary, as specific as you can to your particular patient. So for instance, for me, with a patient, when I go to code his pressure wound, I need to make sure that I'm very specific as to where this pressure wound is and what type of pressure wound it is, right? So the code would be pressure ulcers in general. The code starts with L89 dot. Okay, L89 dot, right there, you know, or I should say L89 period. And then after the period, the code changes based on the location and the stage. All right, so a pressure ulcer on the right hip, that's a stage 2, would be an L89.212 versus a pressure ulcer on the left hip would be an L89.222. Okay, so this is what it means in terms of making sure you're very specific with your particular coding. Okay, so very important, the rule of never coding directly from the alphabetical index without reviewing the tabular also applies to never coding from an instructional notes within the tabular without first reviewing the actual tabular listing of the code. Again, these coding instructions are specifically for a coding class. In terms of being an APRN in coding, again, you're going to have specific reference tools that you're going to use to figure out your codes. Okay, the important thing is just understanding the importance of reviewing your chart and looking at your patient's documentation as to what's already happened in their life. Now, beautiful tool in your textbook. Unfortunately, I couldn't actually get the image, so I had to take a picture of it. So I'm sorry if it's a little blurry, but it's right in your book, in your NP book, page 1339. It's a fantastic chart auditing tool. It's reference used to justify CPT coding. So the first thing you're going to figure out in your CPT coding, first thing, every patient, no matter what patient, no matter what type of care you're in, is you need to establish, is it a new patient or is it a patient you've already seen before? So is this a brand new assessment or is this a follow-up visit? Okay, very basic. Is it new patient or follow-up patient? Now, what is a new patient considered? Everywhere you go, a new patient is considered a patient that has not been seen in the last 3 years. Okay, if you've seen that patient in the last 3 years, then it's already an established patient. So in this particular chart right here, as you see in the top left, this is specifically a chart auditing tool for new patients. These are our codes. So, okay, first thing I need to establish, I've established the patient I'm about to see right now. It's a new patient. Okay, great. So the first thing I know is that code is going to be a new patient code. So I can use any of these codes under this list here, 201, 202, 203, 204. All right, how do I decide which one? Now I need to figure out is what the focus is here on this visit. Is it a level 1 patient, a level 2 patient, a level 3 patient? How do I know? How do I figure out the levels? Okay, it depends on the medical decision making. Is it going to be a straightforward patient? Do they have, so figuring out if it's a level 1, you need to have these particular things in your documentation, in these elements, these 3 elements. You need to have historically, you need to have an HPI of 1 to 3 elements, review of systems or past surgical history, doesn't matter, but you do need to have 1 to 3 elements from your HPI. And you need to have single system 1 to 5 or multi-system 1 to 5, and medical decision. It shouldn't take you more than about 10 minutes to work with this patient. Now, me in my wound care consulting, it's pretty rare that I see a level 1, but once in a while it happens. Pretty rarely though, to be honest with you. Most of the times we're seeing level 2, level 3, level 4, level 5. Okay, so this is how you figure out for, again, it's pretty much the same for both new and established. The bottom line is if it's new, you need to use a new code. If it's an established patient, that's a patient, the patient has been around, you've seen that patient in the last 3 years, then you're going to do an established patient. And you have those visits, they start at 99211, 99212, and so forth and so on. So new patients need all 3 criteria: history, exam, and medical decision. Whereas an established patient requires 2 out of the 3 criteria. Okay, history, exam, and medical decision. So again, these charts to figure this out in terms of coding are in your book. Now, what I wanted to show you, so here, this is on page 1339, just so you know, this is a reference tool to justify your CPT coding. So the first thing we've established is new or an established patient. This is the tool they give you in your book. Here is a tool that Professor Kavanaugh used in practice that she wanted me to share with you guys. It gives you a little more details of how you're making your medical decisions and what exactly you're documenting. So again, this is for a new patient. So I have never seen this patient before. So now we're coding at level 99201. So basically you're going to have the options for a new patient to code between 99201 to 99205, depending on if you're doing level 1, level 2, level 3, level 4, or level 5, right? So if I just decided I'm going to code this new patient as a level 1, that means they only have one self-limiting or minor problem, for example, a cold, an insect bite, or tinea corporis. Again, nothing major, right? So level 1. Again, remember on the other, this chart auditing tool, they kind of used like a time frame. So you're also looking at time in terms of, coding. No matter if it's new or an established patient, if you're spending an extensive amount of time, guess what? You're going to consider moving down into level 4 or 5. Okay. For me, level 4, level 5 are patients who have multiple wounds, multiple comorbidities, the wound care or when I go into assess this patient, the visit itself takes me about 45 minutes. And the visit itself not only takes 45 minutes, but the amount of collaboration that I have to do, whether it's calling the primary care physician or putting in new recommendations and making sure somebody is actually going to put the orders in for me, like all of that stuff that I have to document in terms of phone calls I had to make to talk to the family, get consent to debrief at the bedside, all of that is documented in this exam. Okay. You have to include all these elements: the history, the review of systems, and justify why the time took me 45 minutes. Okay. So anyway, so we're going back. We're looking at a level 1 patient, which we code new patient, never seen him. or haven't seen him in 3 years. They have one minor problem. So I'm documenting that it was just one very minor problem, cold. They have patient has a cold. In terms of their history, the reason for their visit, I'm going to do an HPI, very brief. These are the elements that I have to include in my HPI when I'm documenting. So here the guide tells you, you're going to keep your HPI elements very brief. You're going to include 1 to 3 of these elements. So in terms of the HPI, 1 to 3 elements about a cold, tell me, how long has the cold lasted? Does anything make it better? And associated signs and symptoms. Those are the 3 elements I'm going to include in my documentation for this level 1 patient. Okay, I don't have to do review systems. I don't have to do PFS. Okay, and we're going to do also include in our documentation problem focus for one organ system or body area. So the problem we're going to focus on is they're cold, right? Like, what is their respiratory system? What's going on with their respiratory system? And we're going to talk about that in the exam. Again, 10 minutes, very small problem, a cold. We're just including the quality, the timing, the modifying factors, and then the elements in the organ system. That's level 1. Okay, now we're moving up to a level 2 patient. That's brand new. I haven't seen him in 3 years, or I've never seen him at all. We're going to code him in a 99202. Why am I coding him in a 9902? What happened? What's going on with this patient? First of all, he's a level 2. Already he's a level 2. I know we're looking at least 20 minutes with this patient. Okay, so what do I have to include in my documentation for a level 2? I'm coding him at a 99202. I need to make sure I'm documenting. Also, it's one little problem, but they have a few more issues, more than just the, like they're just complaining of a small cold. Now they have some other things. They also have a cough, a cold and a cough. All right. So again, we're keeping our HPI brief in terms of documentation. We're including 3 elements. We're talking about those 3 elements in our documentation. We're doing a review of systems, one review of systems. So in this case, we're going to do respiratory, and we're going to talk about 2 to 5 organ systems. So in terms of 2 to 5 organ systems, if this patient had other issues going on besides the cold, let's say he's got the cold, plus he's also got associated, itchy eyes or something. So again, now we have 2 body areas being affected by this particular problem. Okay, so this would make it a level 2 because now we have 2 different organ systems we're talking about. Okay, so now let's look at a different patient, also a new patient. Now we're looking at a level 3 patient. So this patient could have, would have to have 1 to 2 stable chronic conditions or 2 or more self-limiting minor problems. Okay, so those are what you're documenting. You're going to document they have 2 stable chronic conditions or 2 plus self-limiting minor problems that are going on. Again, let's look back at our other tool just to remind ourselves, this is a level 3 patient, also kind of low complexity, but still takes about 30 minutes, okay? So for me, in my practice, the majority of patients I see are level 2, level 3, level 4, okay? And again, we have similar guides, but again, my particular specialty is wound care, at this time that I'm practicing. So our guide is a little different in terms of documentation because obviously our documentation focuses around the wounds. So level 2, level 3, level 4 for us would be like low, moderate, and then high acuity, okay? But that's how you use this guide. And please, guys, review this, practice it. There is a great video by a nurse practitioner who works in an FNP practice that I posted on Canvas. She actually created her own little tutorial, a practice guide just like this one, and she actually, you can follow along her video, and she gives you some great examples and really breaks it down from a primary care practice standpoint. So I was thinking about including that in this presentation, but it would have taken so long already with the other things we need to cover that I figured I'd let you guys do that separately on your own. So that you can really get a fine-tuned practice with how you're coding. Please also print these guides and you apply them to your own practice in clinicals and see how, if you're getting the same codes that your preceptor is getting for your particular patients, just to make sure you guys are thinking the same way. So use the reference tool in your book. That's a great chart auditing tool, as well as this one that Professor Alana did. Now, keep in mind, look at the top. This is for a new patient. And then we have for established patients. Okay, same thing in your book. You have two different codes. So your established patients start coding at 9211 and go to 9215. Okay. So here's your established patients. A level 1 would be just basic stuff, checking doing a blood pressure check, filling out a script. They came in just to get review labs, no big deal. It was like a 5-minute conversation. All right, you're in, you're out. Okay, that's a level 1. Level 2, again, an established patient already. You've seen them in the last 3 years. They have one self-limiting problem. And then in terms of documentation, look over in your history and exam, and these are what you need to include. And look at the bottom here, which is beautiful. It gives you exactly how to, your guide as to what to document. This is actually a fantastic tool, guys, especially as a new nurse practitioner, when sometimes you're completely overwhelmed and have no idea even where to begin in terms of documentation. This gives you the perfect, like, paint by number. This is what you do. This is how you write it. Okay. And it really does give you a very focused, systematic way of approaching your documentation as well as your patient, because you can kind of start to think in these terms, and it really helps guide your assessment. After a while, you're going to have patients walk in and you're going to be like, oh, he's a level 2. And then you're going to be like, oh, she's a hot mess. Oh, she's a level 4, or she's a level 5. And then just make sure you're documenting why the person is a hot mess and all the different reasons how you can, justify that. Okay. So I just wanted to give you an example. Like I had mentioned before, every different company, every different practice has their own little software and way of billing and way of teaching their healthcare practitioners how they want coding, and they give you like a little in-service. So in my job, I took a picture of our screen. We have a beautiful checkoff kind of software. So we just go in, click, 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 and this is how we bill. So my particular patient, every single patient has this particular page in their chart. And what I do is immediately, the first thing is for SNF billing. And remember, I'm in skilled nursing facilities. So our codes are different because we're in skilled nursing facilities, but that doesn't matter. It's still the same premise, just like it will be for you with whatever facility or place you're working. We have new patients and we have follow-up patients. That's the first thing we have to establish. Is this a new patient or is it a follow-up patient? New patients I haven't seen in 3 years or have never been seen. Follow-up is I've seen them in the last 3 years. So this particular patient I was going to see that day was a follow-up patient. And I already knew just from seeing this patient multiple times that it's a moderate acuity. The patient has, I think, in this particular instance, usually with moderate acuity, we have 2 to 3 wounds, if not more. Just really, it's more, what are we doing in this particular visit? Was there any changes? Is the wound stable? Did I have to make adjustments in my recommendations? Did I have to order any lab work? Those are the things that I have to consider in terms of moderate versus high. Low acuity for me would be more of what we call our skin sweep patients. So in every quarter in my job, I have to go through every facility I go in and check the skin of every patient in the facility that I haven't seen in the last 10 days. Now, hopefully, for the most part, the patients I'm seeing that I'm doing during a skin sweep don't have anything, most of them, hopefully. So if I go in and the only thing I find is that they're incontinent and, there's no skin breakdown, that for me would be a low acuity patient. I saw the patient, evaluated their skin, they have no breakdown. They are incontinence dependent. So the recommendation I'm making is that I would recommend we apply moisture barrier every shift and as needed to the sacrum, right? Again, low acuity, nothing I had to really do there. It was less than a 5-minute visit. So that's a low acuity follow-up patient, 99307, okay? Moderate acuity for me, and if you look over on the left, this is our little cheat sheet and we need to make sure that we're focusing our documentation, which was provided by CMS. As you can see, this is a CMS guideline. Remember, of course, all the guidelines and reference tools you're working with, you want to make sure they're from an accredited body, okay? So here, this particular coding sheet is for 99309, which is the higher acuity. And what they're trying to show you in this particular, that's why they have it red, but they actually give you the reference for each one in terms of what is expected. And as you'll notice, as the codes go up into the high complexity 99310, you're going to need a comprehensive history and exam. Problem focused just for a low acuity. Moderate acuity and 99308, you're going to need expanded problem focused. And then of course a 99309 is a detailed focus. So for me, a 99309 could be multiple wounds. It doesn't necessarily have to be multiple wounds, or it could just be a wound that is now decompensating, that I needed to order labs, I needed to order diagnostics, I needed to order make recommendations for antibiotics, IV antibiotics. I wanted to get an x-ray to rule out osteomyelitis. I needed to collaborate with the in-house physician to discuss the plan of care and maybe make a hospice referral. Like, these are all documentation, things I would be documenting to justify my moderate or high acuity. But again, here, this tool is showing me, okay, why is it the medical decision more moderate or high? Because of the comprehensive history and exam, and the presenting problem, the severity of the presenting problem requires, immediate physician attention. And again, they're giving you times, remember? So high acuity for me definitely is a patient with multiple wounds, because right there, the time is gone up. Now, that being said, I have to also justify not only that it's taking me a lot of time that I'm in there, why is it taking so much time? Are the wounds decompensating? Is the wound care very complicated? Why is it complicated? And again, I'm documenting why, and that's justifying my high acuity. Okay, so that's how we do our coding. And again, I can't stress this enough, guys. Understand the basics of it. Established or new patient, understand the severity of what's going on with the patient in terms of how long is it going to take you? How many problems are going on? Is it a complex, low, moderate, or complex medical decision-making that's going on with this patient? And how, what's going on with the severity of the presenting problems? Okay, these are all factors to keep in mind in terms of coding. Okay, so use these tools as your resources. Again, I would go on YouTube on the video I posted from the NP Real World, where she really does a beautiful breakdown of primary care and how she uses those codes in primary care. And please use her tool and practice with her so you can make sure you're understanding how to code. Okay, because that will be on your quiz. You will be quizzed on CPT coding. Okay, because it is so important in your practice. It is. There's one of the most important things. If you can't code, you can't get paid, and that's a problem. Okay, so let's get into the idea of the electronic medical record. All right, so this, obviously in business, we want to talk about the EMR. You guys have all been exposed to EMRs in all the different institutions you work, so I don't really need to get into this too much, but, obviously understanding the electronic medical record is part of, your practice. So EMR records were mandated for providers by 2014, and President Obama's stimulus package contains a $20 billion investment to make electronic records happen. Now EMRs are required for all medical providers, so we all know that. What are the benefits of having an EMR? Obviously, longitudinal patient care record, track care to all delivery centers, including the patient's homes. Emphasis shifts to care across the continuum of versus each episode. So obviously it's really helpful when you open up a patient's medical record and you can see everything that they've gone through, especially if they continue to come to your particular facility. So patients that I've seen and that I've consulted on that will stay in their records, I can always pull up those consultations if I end up seeing them again in either the same facility or a different facility. And I can see if they've had previous stage 3 that's healed, that I see scar tissue that's now reopened. Like, I can see all of that. And it actually is so helpful because then I can justify, okay, this was a stage 4 before, it's reopened. Obviously the patient is at higher risk because it's very fragile tissue, blah, blah, blah. So this is all stuff that I can use that if I didn't have an electronic medical record, I would have no idea, right? And the patients, their own stories to their healthcare is sometimes they have no idea what's going on. And it definitely allows for universal patient identification, of course. Keep in mind, there is the, Connecticut has its own website specifically to track the use of narcotics and prescriptions for narcotics. You guys will have access to it once you get a DEA number and you're prescribing and you work in Connecticut. I do not have access to it, otherwise I'd show it to you, but I did see it quite a bit when I was in pain management, when I did my pain management rotation. Anybody, the pain doctors who are prescribing, they go and look at this website and they're able to see from any patient who's been prescribed specifically in Connecticut, but actually across the country, if the providers are using it, they can see what the patient has been prescribed in terms of narcotics, when it was prescribed, and how many were dispensed, so that they are 100% sure that the patient is not abusing their prescription. So again, another benefit of having an electronic medical record. Now, the question is to reflect on, do you think today's APRNs are prepared with the business skills needed for independent practice in this changing healthcare delivery model? So the one thing I'll point out in terms of having an electronic medical record, yes, it's great, but the one thing you have to realize as an APRN, you better be good on computers, because you're going to be on a computer, a tablet, everything you're doing is technological. Okay, so I'm going to just mention to you guys, reach out to our tech support within Goodwin University if you have any issues with your computer, your phones, accessing Canvas on your phones or your iPads. Everything is accessible. If you're not able to get access, please reach out to our tech department. And I'm only saying that because I wanted to encourage you to start utilizing your tech department through Goodwin, because as you start practicing, you're going to find you're going to be utilizing your tech department through your company as well. And you want to have a good relationship with them, because technological stuff comes up all the time and you need to make sure you know how to deal with it quickly, because it will delay your charting. And believe me, that will throw your game off for the entire day, because if you delay your charting, you forget stuff, and then patient care is delayed, and there's just so many problems that come along with having your computer not working or your tablet not working. So just be very proactive when it comes to managing your technological items. And if you're finding things are slow or just not 100%, do not hesitate, reach out to your tech department, okay? And I think it's great to have technology. The one thing I want to point out is every nurse, every APRN I come across, even physicians, most of them carry around a piece of paper, something they're using that's like they can write on right at the moment. So, just always keep in mind, computers, internet, when those things go down, suddenly you don't have access to anything. And that's a big problem. So the one thing I make sure to print every single day, so I have it on my person, and just in case, whether the iPad dies, the computer dies, electricity goes out, the internet goes out, whatever, I always have a list in front of me of who I'm seeing, names and date of births, just so at least I can write next to them and I can keep track of what's going on in that respect, because days get crazy. And when you're seeing 30 to 70 patients a day, which some of you may end up doing, a lot of you, you really have to keep things organized. The other interesting thing is about technology, in APRN school, you don't really learn how to use a computer. You don't learn how to use Excel. I never knew how to use Excel, but when I started this, my consulting job, I was forced to learn how to use it. It was such a learning curve for me. I really struggled with it, but now I use it, and I have to use it because my job expects us to email facility reports via an Excel document. So my job, taught us how to use it through a kind of a tutorial video. And I had to watch the video like 100 times before I actually learned it. But it's now such a phenomenal organizational tool for me to use, not only for my job, but for school, managing, my just daily to-do tasks. So just keep in mind, those are things that you may end up having to utilize and learn as you start your practice. Okay, value measurement. All right, so what are we talking about in terms of value measurement? This is how we measure and make sure, all of our documentation and everything we're doing is under compliance and being strategically managed, so that we're all following the same standardized guidelines, okay? So we have all these compliance things in our particular practices, whether it's your private practice or the company you work for. All of these things need to be set up. Otherwise, you're out of compliance. So a fraud and abuse compliance plan, HIPAA compliance plan, risk management, HEDIS reporting, safety and performance improvement initiatives, and value-based healthcare. So all of these things you will be going over when you are hired at your particular place of employment, and they will be reviewing all of these things as part of your orientation. Make sure these things are in place, because again, you don't want to be working for some shabby healthcare institution that doesn't have these things in place, and then, then liability falls on your company, and it's just because they didn't have basic standardized things in place. So as an APRN or a nurse practitioner, you need to be aware of these particular value measurements and how important they are in any practice you work in. So it's compliance plans and risk management are important components of all healthcare businesses. They prevent episodes of fraud and abuse. Risk management is an extension of performance improvement. So it prevents undesirable events from happening, and then it minimizes the financial impact of litigation claims. HIPAA and performance improvement. So obviously we all know what HIPAA is. It's the Health Insurance Portability and Accountability Act of 1996. And then we have performance improvement, where APRNs are valued for their ability to identify familiar patterns and to use institution and keen assessment when options for interventions are needed. Okay, so let me just do a few things. So, okay. So the compliance plan, anti-kickback efforts, conflict of interest disclosure, and identifications of questionable business practices require all oversight of all providers and includes all employees. So this is what I'm saying in terms of being a nurse practitioner. It even falls higher on you. You're now in a higher level of professionalism. So anytime you go into a higher level, now you're even more responsible for certain things, specifically like these compliance standardization. So if you're in a practice, especially a private practice, you want to make sure all of these little programs are in place. Your risk management programs, all of your stuff is on point, because again, you're the APRN of the practice, and the likelihood is that will fall on you to make sure that you're responsible for making sure the standardizations and performance improvement plans are in place in your particular business. So just be aware of that. Keep in mind, HIPAA protects health insurance coverage for workers and their families when they choose, HIPAA Title I protects health insurance coverage for workers and their families when they change or lose jobs. HIPAA Title II addresses administrative simplification and requires the Department of Health and Human Services to establish national standards for electronic healthcare transactions. So HIPAA Title II is actually specifically for the security and privacy of health data. In terms of performance improvement, policy should be made a part of day-to-day practice. Establishing quality indicators that can be collected and monitored provides the practitioner ability to monitor trends and identify changes in practice. Okay, so quality reporting. The consumer call for safe and effective care and has created a variety of outcome measurement websites and reporting criteria. For example, the health plan employer data and information set, which monitors current healthcare issues and the outcomes of care. So keep in mind, in the state you're licensed in, the beautiful thing is you're going to get emails with all the newest up-to-date Department of Health stuff that's going on. So you're going to know right away. Like, for instance, when they took the Johnson & Johnson vaccine off the market there, immediately before I even heard it on the news, I had already gotten my APRN Department of Health notification, because keep in mind, we're prescribers. So if we're prescribing and we're prescribing for our patients to get vaccines that are now off the market, we need to know that, right? So the Department of Health definitely standardizes and sends out emails. So make sure that in your email account, when you start getting those emails, it doesn't go to your junk email, because you do need to read those and be very aware of them. In fact, a lot of the times in my last practice that I worked in, I would get those emails and I would print them and make sure everybody in the practice had a copy of it. So we were all on the same page in terms of knowing the most up-to-date standards and requirements. Okay, managing a healthcare business. Again, just like managing any other business, we got to make sure we have the basics underneath, right? APRNs are managers of a business. They affect the financial health of their practice. So obviously, if it's your business, you're going to be affected by the financial health. So you want to make sure you know how to manage your finances. All right. So It's not just about managing a healthcare business in terms of owning a private practice. It's also about managing yourself because you are your own business, right? So in terms of approaching jobs and starting to apply for jobs, one of the things we wanted to make sure we talked about is salary and negotiating a salary with your future employer. So a couple of things I want to point out to you before you even start to think of the number you're going to ask for in terms of salary. First of all, you need to remember your worth as an RN. Remember how many years of practice you have and years of experience you have as a registered nurse. That needs to be very well reflected in your resume, okay? And you need to remember what you bring to the table in terms of your experience and your knowledge base. Just because you're a new NP does not mean you need to feel like you should ask for less money, okay? What else did I want to say? So the interesting thing was when I first started practicing as an NP, my colleagues that I went to school with, grad school, a lot of them had just about the same, if not more years of experience in different fields than I did. And some of them were working in Connecticut, some of them were working in New York. And I found that after I had applied for a few jobs and I came up, I was offered what I was offered, and I, whether I had asked for something and they gave it to me or vice versa, they gave me lower or higher, whatever. I went to my colleagues and I started to kind of do a little questionnaire with them to see what they were asking for and how much they were being offered. And a lot of them were very disappointed with their salaries that they were offered, because a lot of them found that the salaries they were going to be starting with was either just as much as they were making now as RNs or even less, because a lot of them worked so much overtime that their salary was, through the roof. I did not have that issue because I really didn't work overtime when I was in school. I just couldn't, I had to find a balance. And for me, I just had to cut back because I just wanted to finish, and I had to find a balance, and that was it. So anyway, the point is, make sure you know your worth. And that was what I wanted to point out, with that I actually had to reinforce with a lot of my colleagues was, I did not, I had a baseline number that I would not go below. Now, the bottom line is, as a nurse practitioner, I expected to be making six figures. I didn't care what anybody said to me. I was not accepting less than six figures. And that was the number one thing that I went in with every job. And I still do to this day. And obviously, as time goes on and you have more and more years of APRN experience, the numbers that you can ask for in terms of negotiation can go up. The other thing I want you to really keep in mind in terms of negotiation is realize a lot of these places need you more than you need them. And that's the reality of it. We're in a market right now, thankfully, where a lot of us will never have to worry about finding a job again, number one. Number two, the demand is so great for healthcare practitioners or nurse practitioners that you really could ask for what you want and you'd be surprised. The likelihood is they may give it to you. Okay, so that's just a thought. So things in terms of managing your healthcare business, besides negotiating a salary, obviously we're establishing employee benefits. So these are other things you want to look for besides just your salary. What are the benefits? Do we have hospital privileges? Are they going to be paying for your liability insurance? And in terms of your own practice, if you're opening your own practice, these are things you want to also look at. Negotiating salary for your employees, establishing employee benefits for your employees. Do you want hospital privileges? That's something else you have to look into. Are you going to be getting practice insurance for yourself and your employees, or just for yourself? You're going to obviously develop a strategic business plan and establish a marketing plan. Like, how are you going to advertise for your business? Okay, so in your book on page 1345, there is a beautiful business plan table. And I love this. When I was in grad school, one of the first classes I took in grad school, they asked us to write a paper on a business plan and how we would see ourselves running our own private practice. And I still have that paper from when I was in school, and I still plan on using that as the baseline for my business plan when it is time for me to open my private practice. So I would highly encourage you guys to take this table and apply it to your own dream business plan and your own APRN dream business, and get creative with it and use this table and fill it in for yourself. And I will definitely consider giving you guys some extra credit. I'll review that with Professor Kavanaugh to see how much extra credit I can give and where I can apply it. But I will definitely consider extra credit if you guys want to hand me a business plan, you know, kind of listed out like this table. Please be creative. Use your, you know, the sky's the limit. There are no boundaries in terms of, you know, what you dream of for your own business. So feel free to use this table, and you can just email it to me if you want. Okay, let's just do a quick review, knowledge check. We're almost done, guys. All of the following services are covered under Medicare Part A, except, again, I highlighted this for you to reiterate, make sure you're reading the question when you go to take your tests. All of the following services are covered under Medicare Part A, except, and the first one is inpatient hospital care, inpatient psychiatric hospital care, custodial care, or SNF care. So the exception is custodial care. Keep in mind, Medicare Parts A and B do not cover custodial care or nursing home care. Medicare Part A coverage includes inpatient hospitalization, inpatient psychiatric hospitalization, and skilled care given in a certified SNF. Okay. Some nurse practitioners bill directly for their services. Regarding reimbursement, who is considered a third-party payer? Is it A, patient, B, healthcare providers, C, health insurance companies, health plans, Medicare and Medicaid, or D, federal government? Correct answer, of course, is C. Those are our third-party payers. Third-party payers are health insurance companies, health plans like HMOs or PPOs, Medicare and Medicaid. The first party is the patient. The second party is the healthcare provider. So we keep saying third party. Just keep in mind the first party is patient, second party is the healthcare provider, the third party is the payer. Medicare Part D reimburses for which of the following services? Is it A, preventative healthcare such as routine pap smears and physical exams, B, prescription drugs, C, alcohol misuse abuse counseling, or D, over-the-counter drugs and vitamins? And the correct answer is B, prescription drugs. Medicare Part D is a voluntary program that charges a premium, meaning patients can either buy into it or not. It's up to them. Like all Medicare services, patients need to enroll during the open enrollment period during the year. Okay, there's a penalty for late enrollment. There is a drug formulary when you do subscribe to Medicare Part D, and not all drugs are available or reimbursed. Use of generic drugs is preferred as there is a spending limit. Medicare Part B will reimburse for alcohol misuse or abuse treatment, which is good for you guys to know because I'm sure you're going to come across alcoholics who need rehab. So keep in mind, if they have Medicare Part B, that is covered. So yes, Medicare Part D is something the patients can enroll in if they do find that they're on a lot of prescription drugs and they're going to need help financially covering all those drugs. But keep in mind, there is a drug formulary that they have to follow. So not all drugs are covered on there. That is a formulary you're going to want to keep readily available in your practice so that you know what to prescribe and what not to prescribe for these particular patients. Because believe me, if they can't afford it, they're not taking it, and therefore there's no point in prescribing it. Okay, so here's just some things to reflect on in terms of all of this information we just went over. How will the nation cope with a surge of newly insured patients? Well, obviously they're going to need more practitioners to handle all these patients. So again, it gives us more opportunities for the APRN role to evolve and to ensure high quality care at a reasonable cost. With a shortage of primary care physicians, how will the industry resolve the workforce issues? Again, that's where the beauty of the APRN role comes into. We're finding that, especially in rural areas, that the nurse practitioner has now become the primary care role, or has taken over the primary care role. How will the growth of those 65 years and older affect healthcare? So that's an interesting question. Obviously, they're going to have more comorbidities, and they're going to need more long-term care. And how can APRNs move toward practicing to their full scope of practice? So that takes time, of course, and that also takes a lot of knowledge base of knowing what your scope of practice is. Okay. More reflections. Can the profession expand NP's knowledge of the financial and economic factors challenging healthcare delivery? Will NPs be able to embed data collection in their daily function and use this information to improve efficacy and care? So that's an interesting question. And what exactly does that mean? For me, I've kind of done this, and I've noticed a few NPs that I've followed in the past have done this too, where they create templates for themselves based on diagnoses so that they can kind of copy and paste certain verbiage that they're going to consistently say for certain diagnoses and include that in their notes. And I have done that too. I've created my own side documents, and not that I copy and paste it and use it exactly, but I do use certain verbiage, and then obviously I edit it as needed for that particular patient. But I do find that helpful, especially when you have patients with the same consistent comorbidities over and over again: hypertension, obesity, peripheral vascular disease, CHF. Like these particular diseases and these particular diagnoses have the same consistent documentation that's expected to go with them, especially in my particular area of expertise. So I have that stuff already pre-written, and I have it in a file, and I just copy and paste it as needed. And it really actually speeds up my documentation in that particular moment, as well as the efficacy of my documentation. Will tomorrow's practitioners embrace innovation and process change in order to create a viable healthcare system? Well, we hope so, right? That's the goal. Okay, so PPACA or Obamacare has increased the number of uninsured citizens. What do you think are the opportunities for APRNs? Well, obviously it gives us more opportunities to see more patients because now they can pay. How should APRN leaders educationally prepare tomorrow's APRN students to meet the needs of the upcoming healthcare industry changes? Okay, so just like we're doing, we're giving you all the resources and the websites where you're going to go to continually check to make sure that you're keeping up to date with the changes. All right, and you're going to bookmark these: the CMS website, Medicare, Medicaid websites, your licensure websites, your certification website. All of these websites you're going to keep in your little, you're going to bookmark these sites, hopefully, so that you can always make sure to refer back to them when needed. And what are the business strengths and values that APRNs uniquely bring to the US healthcare system? Well, that's an interesting thought. Obviously, we bring a lot to the US, to the US healthcare system just in the care we're providing. So that's it, guys, for today. I just wanted to reiterate the importance of checking Module 1 for those sites that I listed at the beginning with your licensure websites, your certification websites, NPI, DEA, all those things. Keep those in your bookmarks, and also look at that YouTube video. Please review your coding. I already downloaded the tool for you that she used. It's like a cheat sheet. It's already uploaded on Canvas, so you can print it before you can watch it, so you have that tool to use while you're practicing your primary care coding. And then, of course, the telehealth billing for nurse practitioners article, please review that as well. I hope you guys have a great week, and I will see you next week.